Charge ഇല്ല.
ഫോട്ടോ ഇല്ല ഇപ്പൊ ഓണുള്ളത്. മക്കൾ അങ്ങോട്ട് ചെല്ല്.
ചാർജ് എவ்வளவு?
മതി പെരിയമ്മ വിളിക്കണ നോക്കി.
കംപ്ലീറ്റ് ചാർജ് ഇല്ല.
എന്താ 97%.
പിന്നെ അപ്പ ചാർജ് ഇല്ലെന്ന് ചൊല്ലിച്ച് ചുമ്മാ ചൊല്ലിച്ചത്.
ഗവനിച്ചിരിക്കാൻ മാട്ടാറില്ല. അതിരിക്കട്ടെ. അമ്മ ഏതാ ചൊല്ലുന്നു?
വീഡിയോ ഡോറ് വെളിയില പൂട്ടിട്ട് കേട്ടോ. ഗുഡ് ഈവനിങ്.
Good evening, ma'am.
Good evening, ma'am.
Good evening, ma'am.
Shall I start, ma'am? Hello.
Yes, ma. We'll start, ma.
Okay, ma'am. Happy wish to all of you. Happy wish, ma'am.
Yeah, wish you the same.
So, audio, visual, audio and.
Yes, ma.
Listen,
Everything is
listen,
very clear this time. No problem.
Okay, okay, ma'am. Thank you. So, presenting this case is a case of a 79-year-old gentleman who is a resident of Palakkad. He's worked in earlier in Indian Air Force. His presenting complaint was that he had hearing impairment over both sides for past 9 months. There's deviation of angle of mouth towards left with incomplete closure of right eye for past 5 months and difficulty in swallowing and hoarseness of voice for past 3 months. Patient was apparently well 9 months ago in around June 23. Then he noticed hearing impairment first over the right ear, followed by hearing impairment over the left side within 4 to 5 days. The hearing impairment progressed over both ears until he visited an ENT specialist. There was no history of fever, sensation of fullness in the ear discharge, but mild pain over right ear was present, which subsided spontaneously. He visited ENT specialist and was prescribed medications. The hearing loss subsided completely with medications. After 1 month of this event, he again developed hearing loss in the same fashion, first over the right side, followed by the left side. Then he consulted another ENT doctor and medications were restarted. But this time, he did not have any improvement. The hearing loss progressed over next 2 to 3 months to deafness, and he was prescribed hearing aids for both ears. He's on hearing aids for past 4 months. 5 months back, around on October 15th, he specified this single date. On October 15th, he noticed a deviation of angle of mouth towards left with drooling of saliva from right side of angle of mouth and difficulty in closing right eye and excessive tearing from the right eye. The difficulty in closing right eye and facial deviation towards left side, it progressed over next few days and reached its peak in 1 week. Approximately 1.5 months after the weakness of the right side of face, in December 23, he developed severe throbbing headache over right temporal region without any photophonophobia. Vomiting, then Approximately 1.5 months after the weakness of the right side of face, in December 23, the patient developed severe throbbing headache over the right temporal region without any photophonophobia, vomiting, neck pain, diurnal or postural variation with moderate grade of continuous fever with cough and cold. Then he was admitted in nearby hospital with treatment. Fever and headaches improved, but the hearing loss and the facial weakness persisted. About 2 weeks later, after the development of this headache and fever, he developed difficulty in swallowing. The swallowing difficulty was initially for liquids, followed by solid foods. Patient had difficulty in swallowing food bolus, as a result of which his food intake reduced and he started developing weight loss. The swallowing difficulty progressed gradually with frequent coughing episodes on drinking water. Patient also developed frequent episodes of nasal regurgitation of fluids, along with choking episodes, which was gradually progressive. Simultaneously, the patient developed nasal intonation of voice, followed by hoarseness of voice over next 3 to 4 days. The hoarseness of voice gradually worsened and the patient was able to speak only in whisper. Then he was put on a nasogastric tube in view of choking episodes and regurgitation. There was no history of any alteration of smell, no history of blurring of vision, drooping of eyelids, visual loss or double vision, no history of numbness or altered sensation over either side of face or difficulty in chewing, no history of alteration of taste. He has difficulty in raising right arm above the head since he had right humerus fracture in 1991. There's no difficulty in doing overhead tasks with left upper limb or gripping objects from both hands. There's no difficulty in standing from sitting or squatting position, wearing footwear or slippage of slippers while walking. There's no sensation of wading through water sensation over heaviness over limbs. No tingling, numbness or paresthesia over the face or limbs. No episodes of any incoordination or clumsiness of the upper limbs on doing any task. There's no sleep disturbances, no memory disturbances, forgetfulness or emotional changes, no slowness of movements, stiffness of limbs or abnormal limb movements, no history of any prolonged fever, rashes, joint pain or photosensitivity, no presence of oral or genital ulcers, bladder and bowel habits are normal. There's no history of epistaxis, hemoptysis, recurrent URTI or breathing difficulty. No history of any prolonged exposure to drugs or toxins. In past medical history, the patient had diabetes for past 8 years, which is poorly controlled. Patient has systemic hypertension for past 7 years. He had fracture of right humerus 33 years back and has restriction of motion of right shoulder joint since then. No history of TB in past. No history of previous ear discharge, ASVM, CSVM, or ear surgery in past. The patient consumes a mixed diet, is non-alcoholic, non-smoker, and there is no high-risk sexual behavior. There is no history of single illness in family. His mother developed stroke at the age of 68 years, expired 6 months later. The history of carcinoma colon in son, which is treated. This is his pedigree chart. To summarize the history, he's a 79 years old gentleman with background history of diabetes mellitus and systemic hypertension, presented with acute onset and gradually progressive bilateral hearing loss, right-sided followed by left side for past 9 months, right-sided facial weakness for past 5 months, followed by right temporal headache 3.5 months back and difficulty in swallowing with hoarseness of voice for past 3 months, without any sensory symptoms, limb weakness, cerebellar or autonomic involvement.
Okay. So apparently his comorbidities are only diabetes and hypertension.
Yes, ma'am.
This patient develops a sudden onset of deafness,
Yes, ma'am.
which started on one side and then went on to the other side. Did not simultaneously start on both sides, no?
Yes, ma'am. First right side, then over next 4 to 5 days, it involved left side
One by
also.
one. And you said that there was some pain also, no?
Ma'am, but mild pain was there, which subsided spontaneously, ma'am. It did not take any
pain was there. So we
Yes, ma'am.
want to know whether this deafness is due to nerve deafness or middle ear deafness, and what could be the cause we are wanting to know. And it is very short duration and rapid progression. So
Yes,
it
ma'am.
will not be qualifying for the other causes of deafness which occurs in like otosclerosis or Meniere's disease or other kinds of conditions like mitochondrial vasculitis. They are all not in this age group. So we
Yes,
are
ma'am.
not going to consider the deafness common causes. So nutritional, toxic, vascular, and mitochondrial diseases. Those things we are not considering. We are not going to consider autosclerosis. We are not going to consider Meniere's. So that kind of things are little more slower to evolve. And apparently he is not exposed to any autotoxic drugs.
Yes.
And what are the autotoxic infections, ma'am?
Infections, ma'am. Yeah, CSOM, ma'am.
Mumps, no? Commonly mumps.
Yes, ma'am.
Parotid.
Mumps, parasitis,
No,
Haemophilus
autotoxic sudden. Then you can have it in endemic fever. And you can also have meningococcal infections. So just I'm enumerating just for us to know short duration deafness. So now degenerative causes less likely, nutritional causes less likely. Nutritional also pick up the second nerve and the eighth nerve because they are all high energy requiring nerves. So nutritional, toxic, mitochondrial all depends on energy supply. But we are not expecting a mitochondrial disease to become symptomatic at this age group. At least a little more earlier, and he has been in the army, all those things. So a defective mitochondria of primary nature is very less likely. So the common bilateral deafness, we are not considering. That I am excluding nutritional, toxin by history, like aminoglycosides and all. And we will keep, at that point, if the person has come to us, the key point, next question you are going to ask, is it a nerve deafness or a middle ear type of deafness? Because, sudden onset bilateral deafness can happen due to infections. Leave alone mumps, you can get it in acute vestibulocochlear neuronitis of several viral nature, several viral infections can produce vestibulocochlear neuronitis, and in children it is H influenza. H influenza can produce deafness and pain. So those things we are keeping in our mind. But this person's deafness, even though the pain was very less, there is definitely a history of pain. No?
Yes, ma'am. Yes, ma'am.
So that is a clue for us. So whether it is a nerve or the middle ear disease, when we are thinking, if the pain history is true, he is an army man, so he must be giving the right history only, I am thinking. So if it is, even if it is a tolerable pain, indicates probably it is not in the nerve. The vestibulocochlear nerve is not a painful nerve. Painful deafness in the long duration, you get Meniere's disease because of the endolymphatic hydrops. And in short duration, all of them are middle ear diseases. So taking it into account the pain as a significant complaint, probably it is not an acute nerve disease. Acute nerve disease, as I said, can happen with viral vestibulocochlear neuronitis. Many viruses produce, of which relevant one is H influenza, which can progress to meningitis. They can go into H influenza meningitis, which is also capable of expressing NMDA. So it will be a very grave disease. So that is one possible, one thing which will start with the ear. And then, as I said, mumps, then you have got the meningococcal meningitis, endemic fever. These are all some infections which produce deafness, but most of these deafnesses are nerve deafness. They are not middle ear deafness. So you can have middle ear disease, deafness unilaterally over a long period of time. But when it is bilateral, you have to be cautious what you are dealing with, and he's a senior person. So I am taking the pain as a feature and think maybe it is a middle ear that got affected first. And then you will immediately tell as a negative symptom whether the patient had any ER discharge.
Yes.
Did he have?
No addition, ma'am. No
So
addition.
this age group, specifically we will ask many blood stained ER discharge was there. And it was not there, that you will tell as a negative complaint. So probably it was a middle ear deafness. He started on one side and went on to the opposite side. So where should be the probable anatomy for this? It will be in the petrous bone, where you have got the internal auditory meatus. So somewhere in that area, the infection or inflammation or whatever could have started, because it is bilateral. You are very quickly bilateral. So 1 year infection quickly becoming bilateral infection is very uncommon when it happens from the external auditory canal. So common infections start as external otitis and they go through the external auditory canal, which I think it is middle ear, and I think it is not external auditory canal. I think it is internal auditory canal. These internal auditory canals are closer to each other, whereas external auditory canals are widely separated and they do not produce immediately within 4 or 5 days opposite side. So something happening in the medial, in the middle of part of the petrous bone, in the internal auditory canal region, maybe some inflammatory or infiltrating pathology may be starting. That's what I feel. And I taking the clue. Other features for a middle ear deafness will be, what are all the points by which you differentiate middle ear deafness from nerve deafness as a revision at this point?
Then there will be pain, fever, sensation of fullness in the ear in the case of middle ear deafness,
Yes.
ma'am.
If all these
Ear
things are there,
discharge.
it is favoring middle ear deafness. Second
Then,
point.
ear
What
discharge.
about tinnitus? Your
Tinnitus?
tinnitus is, if it is there, it is low pitched tinnitus in middle ear. So middle ear, you said first points, so many features which are indicating a involvement of the middle ear. Second, if there is a tinnitus, it is a low pitched tinnitus. And third, deafness is never complete. Never it is a stone deafness. Whereas complete deafness is more common in nerve deafness. So these are causes for a middle ear. So if it is nerve, all the other first group of symptoms you said will not be there. And tinnitus is usually high-pitched tinnitus. Then you may have some this recruitment phenomena, where some frequencies are specifically affected depending on the type of insult that happened. And some frequencies may be spared. And complete deafness is common in nerve deafness. Then when you do the testing, of course, when it is when you do the Rinne, Weber and Schobach test, you will find Schobach will show that there is deafness. And Weber, if it is unilateral, at that time when it was 4 to 5 days, one side it will lateralize to the side of disease. And in nerve deafness, it doesn't lateral, it lateralizes to the side which is normal. And Weber will be central. Weber, Rinne will be showing absolute loss, and Weber will be lateralized to the side of disease in middle ear. Whereas in Weber will be lateralized to a disease side in nerve deafness. Then of course you can do the audiogram where you can do separately, and you have got many other tests which will help you to know, including the auditory work responses, which will help you to differentiate between nerve deafness and middle ear deafness. So supposing you have a problem which is bilaterally picking up the internal auditory meatus, what could be the location of the lesion? If you draw a cut through the base of the skull, you can draw a section through the base of the skull. I will draw and show you. So what I am meaning. So, simple line diagram I will show. You see, are you able to see this? Are you able to see this picture?
Yes,
This is the skull base.
ma'am.
Here, this is the cella.
Ma'am, a little up,
The
ma'am.
lesser wing
Ma'am, a
of the
little up.
sphenoid bone. This is the
Ma'am,
pit
look a
bone.
little up.
This is the foramen magnum. You see?
Ma'am, it's not visible, ma'am. Can you just
Not visible?
look it up, ma'am?
Is it
Yes.
visible now?
Now it's visible.
So behind you see the foramen magnum. And the middle you see the sella. And anteriorly you have got the superior orbital fissure in the lesser wing of the sphenoid bone. And posteriorly you got the petrous bone. And the internal auditory meatus I have marked in the petrous bone. So supposing some pathology picks up the internal auditory meatus on both sides, it has to start probably from the posterior cellular or paracellular region. So a pathology silently sitting in the posterior cellular region and going both sides can pick up both internal auditory meatus. So probably at that point, always at every step, we will go through the anatomical localization. We may be right, we may be wrong, doesn't matter. But this will be the location for me at this point of time. Secondly, if you want to draw the this is the nasopharynx. I have drawn the sagittal section through the nasopharynx. No? So supposing there is a problem in the nasopharynx, that can also spread like a lotus. You know, it is described that it spreads like a lotus. That I will draw. So if this is the sella, and just below that is the nasopharynx, it can go paracellular, it can go infracellular. So when it goes infracellular, it becomes a lower cranial nerve. When it goes paracellular, it becomes so many cranial nerves which we can come to. So at this point, I feel that there is some problem in this region, which is probably affecting the paracellular, a posterior paracellular pathology, going into both the internal auditory meatus. Probably. And how it improved in the first instance. How much is inflammation? So whether there is a inflammation, and most of the inflammations, when you give anti-inflammatory plus anti-edema measures, they can improve. So this symptom improved first, probably he received some antibiotics
In the
and
first time, ma'am,
anti-inflammatory agents, and that would have made it improve. So probably this is inflammatory, infective pathology is possible. Posterior paracellular lesion of probably infective or inflammatory nature.
First time, ma'am, he was given antibiotics and steroids.
Deviation. So what do you think is the type of facial deviation that patient developed? That is very easy, no? Facial palsy, no?
Yes, ma'am. One day suddenly ma'am, he developed a kind of
what kind of facial palsy you think?
element, ma'am.
So what are all the points in favor of element facial palsy in this patient?
In this patient,
What are
ma'am,
the points, ma'am?
there was
Yes.
first of all difficulty in closing the right eye,
Yes.
as per the history, and right eye, ma'am, he was not able to close at all.
Yes.
Hello.
Yes. So
And
some is audibility slightly disturbed. I don't know why. Some problem is there, but I just want you to enumerate the points in favor of element and UMN facial palsy. So clearly facial palsy is there. First tell element UMN, then tell where in the pathway ETC probably involved. That is a revision that you can do in this case.
Facial palsy, ma'am, it seems more like as per the history, it seems to be element facial palsy.
Yes. So what are all the points by which you differentiate element facial palsy from Yemen, even though it is very common and we discussed time immemorial from undergraduate days, doesn't
Mhm.
matter, it is still worth the discussing. So
Mm.
you tell me the points. Ma'am.
Ma'am, in element facial palsy, the whole of the right side of face would be involved. And
So
as per
generally,
the,
whole of the face gets involved in element, whereas in Yemen,
the upper part of face, ma'am, is spared.
why is the
the-
upper part space spared?
Because it receives bilateral innervation from the
Yes.
patient
Can the
of the
lower
eye.
part alone be affected in element?
Lower part alone,
It can be, no.
it can
Like
be.
conditions like parotid tumors infiltrating, Hansen's disease. So everything there is an exception, but generally the whole of the face will be involved. Agreed. Second point.
Second point, ma'am, in the case of
Something clarity is not there. It is raining there.
maybe, ma'am, outside, I'm not sure.
Is it raining, ma?
No, ma'am, not raining.
Because sound is breaking.
Mm.
Not raining, ma'am.
Because audibility, is it disturbed for all of you or only me? I don't know.
No, ma'am, we are here.
Audibility is
It's
We are,
not
we are able to hear you
It's
clearly,
breaking
ma'am.
for everyone.
I can hear you clearly,
Let
ma'am.
me see. I switched off the fan. Okay, now I am hearing. Okay, ma'am.
Yes,
Go on.
ma'am. Clear, ma'am. Second part, ma'am, as far as element and human is concerned, element palsy is the palsy of the muscles, and the human palsy is the palsy of the movements. So,
Very
as
good.
far yes, ma'am, in this case, if we see only the history, ma'am, the only history which is suggesting of the element type of palsy is the difficulty in closing the right eye.
So I just want you to tell
Completely.
all the points.
Ah.
So you said movement. So
Ah,
reflex
yeah.
movements will be preserved
Yes, ma'am.
in human, like
Human.
corneal reflex, conjunctival reflex, all facial reflexes will be preserved, whereas element, these are absent. Next
Absent.
point.
Next point, ma'am, in UMN, the motor and the
Dissociation between emotional and motor
yes, ma'am.
happens in human, whereas in
UMN.
element, everything gets affected together.
Together.
Next point, ma'am. If there is
Next point.
associated involvement of this hyperacusis, or you have associated involvement of taste, it is favoring element or human?
Ma'am, human.
Element.
Element. Yes,
Element.
element.
So these involvements do not happen in human. Next point. Associated hemiplegia is very common in
Human.
human. It is not at all common in element. Next point. Bell's phenomena.
Element.
Why do you get Bell's phenomena?
Ma'am, because there is a conjugation of movements between superior rectus and the orbicularis or oculus.
Yes.
So if orbicularis oculus is, ma'am, it is paralyzed, then we can see only the uprolling of the eyeballs in element.
Okay. Agreed. Supposing you check one side, your patient is having one side, no?
Yes,
So
ma'am.
when you check both sides, what do you expect with reference to the uprolling of the eyeballs in this patient?
Ma'am, in this case,
In this patient, let us imagine now you are telling the patient to close the eyes. He is not able to close the eye on the right side. He is able to close on the left side. And what kind of uprolling you expect?
ma'am, the uprolling of eyes over the paralyzed side will be normal, ma'am. Both sides, but because of the defective closure of the eyelids, we can see the uprolling of eyelids clearly towards upside. Means,
When you check this patient, you observe it again, no?
yes,
If we
ma'am.
are the patient, we can see, because it will be definitely more. Because it is conventionally taught that uprolling becomes visible because of the paralysis of orbicularis oculi, which is not at all true. The uprolling becomes definitely asymmetrical. This patient himself, you can go back and verify if he's in the ward. When you tell the patient to attempt closing of both eyes, the uprolling will be more on the side of paralysis than the normal side, because this is called, there is a yoked muscle. You have that physiological synkinesis. You might have heard about physiological synkinesis. When we walk, we move our hands. So like that, many activities are synkinetic movements. Similarly, closing of the eye and uprolling of the eyeballs is a synkinetic movement. So muscles involved in synkinetic movements are called as what muscles, ma'am? They are called yoked muscles.
Yoked muscles.
When you move your eye to the right side, right lateral rectus and left medial rectus work together. So these muscles are called yoked muscles. So orbicularis oculi and superior rectus are yoked muscles. So when you try to close the eyeballs, yoked muscles get equal amount of innervation and energy. So superior rectus and orbicularis oculi get equal amount of energy. But with the equal amount of energy, the yoking becomes imbalanced in favor of superior rectus. Because superior rectus is supplied by the third nerve, which is normal in our patient. So it is like a tug of war. You know? So with the same energy, the orbicularis oculi will be producing 1 or 2 millimeter movement, whereas superior rectus moves much more. So now go back and see your patient. The eye on that side will roll up much more, because the answer is, of course, it becomes visible because of the orbicularis oculi weak, but it is breaking down of the physiological synkinesis between two yoked muscles, because these muscles are supplied by different nerves and the other nerve is normal. So the answer is breaking down of the physiological synkinesis.
Okay.
So that is another point in favor of element. So in your patient, a facial deviation, he is not telling about hyperacusis because he is already deaf.
Yes,
So even if hyperacusis is there, now stapedius is involved, it will not become symptomatic. Second, taste, did he say anything?
No, ma'am, no involvement of taste.
So apparently, it is a facial nerve palsy without any accompaniments. Pure motor, no?
Pure motor.
Apparently. What are the situations, locations you get a facial palsy without accompaniments?
Ma'am, facial palsy, when the facial nerve exits the facial.
You have got the facial canal, no?
Yes, ma'am.
Anywhere you can get it, but generally, classical locations, what are they?
When it exits from the stylomastoid foramen, ma'am.
Very good. So when it exists from the stylomastoid foramen, that we call it as Bell's palsy. So Bell's palsy is element facial palsy without any accompaniments. That is Bell's palsy. So it could be Bell's palsy. Second, it can be infiltrating tumors of the parotid gland, where it is all other branches have left. Third location is inside the pons. Inside the pons, it will be keeping company of the sixth nerve because of the facial colliculus. It might keep company of the sixth nerve because of the facial colliculus, which goes around the sixth nerve. But the other fibers are joining the facial nerve only in its descending limb, in the course of the facial nerve inside the substance of the pons. So in the nuclear part of the seventh nerve, it will be pure motor facial palsy. But anywhere, other like deafness and caudatimony are not that much symptomatic. So that is possible. But typically it is in the stylomastoid foramen. But as in this patient, we have already thought of a pathology, probably in the internal auditory meatus, we can still put it there only. With the saying that typically it is seen in the stylomastoid foramen without accompaniments, and next in the substance of the parotid gland, and third in the intrinsic in the pons. But in this situation where already you have a location where the facial nerve is also entering into the internal auditory canal, so we'd still like to put it there only, with an odd feature that other accompaniments are not very symptomatic. When you test, you might find it. We don't know. No?
Yes.
So that is what I am thinking.
Hmm.
Here, quickly you can tell about what are all the points in favor of a subtle facial palsy, chronic facial palsy, all those things, no? Subtle facial palsy, how you will detect?
Subtle facial palsy, ma'am, the patient is able to close the eyelids, but incomplete burring of the eyelids is there.
So incomplete burring of eyelashes, then palpebral fissure,
Yes.
blink rate, no?
Hmm.
Then power of the orbicularis, oculi and auricularis oris, which you can check. Then you have got Barbara Wattenberg sign and Van Graffy sign. So those signs are just to put your fingers over the eyeball, and you will see that queering of the orbicularis oculi muscle will be felt in the hands. That is the Van Graffy sign, whereas it will be not felt in the side where the facial power, at least it will be asymmetrical. Next, other Barbara Waterberg sign, you put multiple writing reflexes, facial asymmetry becomes symptomatic. So tell the patient to bend the head and slowly elevate. When you slowly elevate, the asymmetry in the palpebral fissure becomes obvious. Otherwise, it may not be obvious. Patient may have some irritation in the eye because of the poor blink rate. He may say, when you put this, so many writing reflexes, body on neck, neck on head, and head on orbit, and eyeball on orbit. So many writing reflexes support the palpebral fissure asymmetry becomes symptomatic. Then, of course, the nasolabial folds asymmetry. These are subtle features. Then chronic facial palsy, what you will find? One is hemifacial spasms. Usually it is equally a whole facial palsy. And nasolabial folds become more prominent because of contracture. And facial deviation may be ipsilateral, again due to contracture. And the palpebral fissure becomes narrow on the side of paralysis. But when you check, you see that the power is less. So narrow palpebral fissure, but less power, that is chronic facial palsy. Then you may have other features like jaw winking, reverse jaw winking, and you can have crocodile tears, Marcus gun, no? That is when you are chewing, you get tearing due to faulty reinnervation. So these are features of chronic facial. So our patient, of course, has got an acute facial palsy. So next one. So supposing when you check, you find a middle ear kind of deafness in this patient and a facial palsy, and he has a facial pain on the right side, you said, no?
The
You
pain,
said
ma'am.
there is a pain on the right side.
No,
This
ma'am.
patient is having a pain on the right side, no?
No, ma'am. Around 1.5 months after the development of the facial weakness, he had pain over the head. He had headache over the right temporal region.
Yes,
And
it is a pain on the right side, predominantly
right.
involving the temporal region.
Yes,
So
ma'am.
what is special about that pain? You said it is a throbbing kind of pain. It is not a neurologic pain, no?
Yes, ma'am.
It's
Not a
not
neurological.
trigeminal neurology or anything. So it's
No,
a
no.
throbbing pain. So throbbing pain happens in inflammation, infection, vascular causes, no? And in this case, the key point about that headache is late onset, short duration, persistently unilateral. So whether you can ignore this patient's headache, most of us have headache. They are all soft headaches. They don't have much relevance. Some viral infection, some dental infection, some tension. Every time we get headache. They are soft headaches. But this patient's headache is a definite implication because it is late onset, short duration, and persistently unilateral. And this headache is not having the typical features of raised intracranial pressure. Mainly it is unilateral. Usually ICP headache is bilateral, more occipital, nocturnal awakening, early morning awakening, double vision, projectile vomiting, amaurosis frequens. These are features of ICP headache. But sometimes you can get unilateral headache also in raised intracranial pressure, like foramen of Monroe tumors, cerebellopontine angle tumors, where the headache can be unilateral. But whatever it is, this patient persistently unilateral, late onset, short duration headache. So it is indicating something underlying that. So what are all the situation an elderly person can get persistently unilateral, short duration headache?
Ma'am, it can be giant cell arteritis.
Very good. So you should not forget giant cell arteritis, where if you don't think of that, you can miss it. Even biopsy might miss it because you need a long segment biopsy and patient will become irreversibly blind. So giant cell arteritis, very good. Second, senior person, glaucoma.
Glaucoma.
Glaucoma, never forget, no? So you may have watering from the eyes, patient may have redness, or if it is a open angle, it may not be there. Only in the closed angle you will have all this, it may not be there. Always do not forget to look for glaucoma because treatment is entirely different. Third, anything which is infiltrating in the right side dura or
Meninges.
arachnoid, no? Diploic space of the bones, or anything that directly or indirectly involves the trigeminal supply to the lesser wing of the sphenoid bone in the skull base. So anterior part, I showed the lesser wing of the sphenoid bone that is supplied by the trigeminal nerve. So something infiltrating into the trigeminal nerve or periosteum or diploic space, all these can produce pain on the right side. So whatever my patient is having, he's having deafness, he's having an element facial palsy, and there is some involvement of the trigeminal nerve or the periosteum or the diploic space on that side, no?
Yes, ma'am.
So if you put a picture on the petrous bone, on the superolateral surface, you have got a first depression called cavum trigeminal. You have got the petrous apex close to the paracellular region. Next to the paracellular region, petrous apex contains the sixth nerve. And next you have got the cavum trigeminal. Dolorous canal, we call it as, no? The sixth nerve is. The next to that you have got the cavum trigeminal where the fifth nerve is sitting. So direct or indirect involvement of the fifth nerve can produce a right temporal headache in this patient. Next you have got the arcuate eminence. So in the superior lateral surface of the petrous bone, close to the petrous apex is the dolorous canal. Next is the cavum trigeminal. Next is the arcuate eminence, and lateral most is the lateral sinus. Depression by the lateral sinus, venous sinus. So this problem probably starting from the internal auditory meatus, picking up the eighth nerve and the seventh nerve, probably creeps and involves the cavum trigeminal on that side. I'm just building up the anatomy. We may still be wrong. I am telling how to move along with the patient. Being wrong is not correct. Are you not wrong? Are you logical? Do you have reasons? Do you have sincere efforts? That's all, no? So this kind of combination is a triad. So what do you call this triad? You have got so many triads. So this, apparently we thought it is a middle ear kind of deafness. So middle ear kind of deafness with a trigeminal pain and a facial palsy on that side, it is called as Jacobson's triad. No?
Yes,
so the other conditions where middle ear deafness is neurologically relevant. Can you tell other conditions? So it's a middle ear deafness, neurologically relevant. No? Other conditions, apparently, we are not examining the patient history-wise. No? What other conditions middle ear deafness is relevant? One is glomus jugular tumor. That will produce a vascular mass which may be seen in the ear, and it is a pulsatile headache, as this patient is also having pulsatile headache. and they get lower cranial nerve palsy. And because they are all chromaffin tissue tumors, patients usually develop episodes of palpitation, sweating, and flushing. Because glomus jugular tumor is a chromaffin tissue tumor. But the deafness is middle ear deafness. Next condition where middle ear deafness is relevant is cholesteatomas. Chronic CSOM producing destructive pathology of the petrous bone and picking up the cranial nerves in and around. It will pick up the same kind of nerves only. So that's just a cholesteatoma. But they also have little more subacute course. Not this fast. Cholesteatomas, glomus jugular tumors do not come this fast. So this is very fast. So I will think my patient at this point is having a Jacobson's triad due to some pathology in the nasopharynx. So this looks like a nasopharyngeal pathology, which is capable of doing that. And other triad is called Trotter's triad. You heard of Trotter's triad?
Yes, ma'am.
So Jacobson's triad also involves ophthalmoplegia. All need not be there. Trotter's triad is you have got a lower cranial nerve palsy, fifth nerve, and nose block. Nose block on that side. That is Trotter's triad. Then you can have all the cranial nerves on one side. That is called hemibasal syndrome. That is also a feature of nasopharyngeal tumor. That is called Garcin syndrome, hemibasal syndrome, carpeting the whole of the skull base. What is Gradiniga syndrome?
Ma'am, it involves the
You get it in chronic otitis media.
yes, ma'am. Chronic otitis media.
Where the infection spreads to the petrous apex, usually through inflammation of the venous sinus, spreading to the petrous apex, thrombophlebitis, and it presents with the sixth nerve and facial pain. So these are the various things. So at this point, we think probably there is an nasopharyngeal problem, and thinking that the deafness is of middle ear nature. After examining it is different, we will definitely revise our diagnosis. No? And 2 weeks later, he developed swallowing difficulty. No?
Yes, ma'am. Yes, ma'am.
So what are the situations where you get a swallowing difficulty, ma'am?
Swallowing difficulty, ma'am, maybe due to involvement of the 9th or 10th cranial nerve, ma'am. Dysphagia may be there. Especially in this case, the pharyngeal dysphagia is more of a possibility, ma'am.
Agreed. So would you like to revise your phases of swallowing and the supranuclear control of swallowing? Just like a revision.
Oral phase, pharyngeal phase, and the esophageal phase.
Oral phase, what are all the muscles that are involved?
Buccinator, masseter muscles. No.
The oral phase, facial muscle, facial nerve. So in this patient, already facial nerve is involved. So even though he has a swallowing difficulty, you should ask, is the food leaking through the side of the mouth? Is he leaking the liquids through the side of the mouth? Then it is not just a pharyngeal phase. You are very much expecting a oral phase. So oral phase is 7th nerve and 5th nerve and 12th nerve. So oral phase of swallowing is by 3 nerves. So if he is already having one, so we cannot say it is only pharyngeal. You should ask and tell whether how many phases are involved. So if it is facial, the food will leak through the side of the mouth. Liquids will dribble through the side of the mouth. And when he he will be able to chew the food properly. But when the chewed food lies in the gingivo-alveolar gutters, it will not be brought to the floor of the mouth because the buccinator is weak. So the food will remain in the gutters and patient will have to mechanically bring it to the floor of the mouth. So facial nerve, you are expecting all this. So you'll ask, is he having all this? And is the food remaining in the gutters? Does he have difficulty in bringing to the floor of the mouth? Next, if it is due to fifth nerve, there will be no leaking, but patient cannot chew. Because the upper jaw and lower jaw cannot be approximated properly, and side to side jaw movement also becomes difficult. So chewing becomes improper. So patient will say he is not able to bite hard materials, and soft materials are not chewed properly, but he is able to swallow. So that is the fifth nerve. If it is 12th nerve, all this is all right. Food is brought to the top of the tongue, but patient is unable to roll back the food to the pharynx. So the food will leak through the middle of the lips. So these are the oral phases. We have fifth nerve some symptom, we thought. So we want to know whether the motor fifth is involved. So you'll ask positively and say whether it is involved or not. We are expecting all those things. So we'll ask leading questions and try to find out. Pharyngeal phase is separating the oropharynx and nasopharynx during the act of swallowing, coordinating the nasopharynx becoming closed by the epiglottis. So that doesn't happen. So patient will either cough or have nasal regurgitation depending on the degree of disability, and they have a nasal tang due to the air escaping through the nasopharynx. So you said there is nasopharynx and there is some nasal regurgitation.
Yes,
so
ma'am.
pharyngeal phase is definitely involved.
Involved.
Then what is the esophageal phase? There usually food becomes stuck in the, so all the other two phases are all right. The food becomes stuck. So patient will say, we have to drink water and push it down. It happens in pressed by esophagus. Many old people drink eat like that, but it doesn't progress. That is pressed by esophagus. Or if you have a polymyositis or esophageal tumors, strictures, all this, it will persist, and pressed by esophagus can be tolerated by pushing water, but strictures, tumors, and polymyositis involving the upper one-third of the esophagus, they are little difficult even in the esophageal phase, and food becomes stuck there. In your patient, apart from the weakness, you developed hoarseness of voice. That means what? You don't have to think about the ninth nerve. So you have to think about the 10th nerve only.
10 nerve.
Always
Vocal
we
cord.
say, yes, 9th and 10th we always tell, but with this hoarseness, it is 10th nerve.
10 nerve. Yes,
So
ma'am.
10th nerve indicates vocal cord, it is supplying the vocal cord. So vocal cord is also recurrent laryngeal nerve. Probably the recurrent laryngeal branch of the 10th nerve is also getting involved. So that is what it indicates. So what does it convey to you?
Means, ma'am, it is a lesion involving till now 8 nerve, 7 nerve, and now it is involving 10th and probably 9th also.
9th, what are the points in favor of 9th?
In 9th, ma'am, that gag reflex will be impaired. That swallowing may be impaired, ma'am. In 9th nerve.
At this point, we cannot tell 9th is involved.
Yes, ma'am.
So 10th is definitely involved. Generally, we tell 9th and 10th together. At this point, it is definitely 10th. 9th, we don't know. We have to examine and tell. And 9th, in which part it is involved, you think?
The
You
9th,
think
ma'am,
said it is in the nuclear part, or is it in the cysternal part, or after it has escaped? Branches are getting involved, no? Motor branches, recurrent laryngeal branch. So when it has escaped only, it is in the branches form. Inside the brainstem, other brainstem features will be there, and it is either the nucleus, some degenerative diseases like spinocerebellar ataxias, they involve only the fibers, which is the inferior part of the tendinous nucleus and supplies the vocal cords that you get in spinocerebellar ataxias. But that is again very slow, steady, and that is very typical of brainstem cerebellar type of spinocerebellar degenerations, but that is not applicable in this. So here it is one by one picking up the motor fibers to the vocal cord and then to the muscles of the soft palate. So and no brainstem features we are seeing. So it is probably getting involved after it exists in the cysternal space.
Cysternal space.
So like what I draw, the lotus-like spread. A nasopharyngeal lesion, superior paracellular can pick up the 7th, 5th, and the 8th, and inferior paracellular in the cysternal space picks up the lower cranial nerve. So it is showing a typical feature of a nasopharyngeal problem. Very short duration. So is it a very aggressive tumor or being a chronic diabetic? Is it some kind of a fungal infections?
Infections.
In the nasopharynx spreading up and down. So logically, this is the diagnosis we will make.
Yes.
Okay. Then what other things he has, ma'am?
No, that is the major.
Anatomy is in and around the paracellular region, posterior paracellular region, lotus-like spread with probable middle ear deafness, all points to a nasopharyngeal inflammatory disease, probably fungal infections at this point of time. Okay, next one. All are other negative, you said, no?
Yes, ma'am. All the others are negative, ma'am.
Okay.
Then
so there is nothing else. So now this is, would you like to think of nasopharyngeal carcinomas?
and epistaxis and all is not there, ma'am. No bleeding.
Too fast, no?
And no sense of blockage in the nose is also not there.
No, that is all not mandatory. As I told, it can be paracellular, it can be infracellular. So, so it need not be that there is mandatory nose blood, but it is very fast. It's only 1.5 months. So little unusual, but aggressive tumor is still present. So first thing is a fungal infection. Second possibility, still I will keep a nasopharyngeal tumor.
Okay. The current functional status of the patient is that he is independent for all his activities of daily living, on hearing aids over both ears.
Is he able to hear with the hearing aids?
With hearing aids, he is able to hear. Without hearing aids, he is not able to hear.
Okay.
And he's on nasogastric tube feeding in view of recurrent regurgitation and choking episodes.
Okay.
General examination, ma'am, good examination. The patient is alert, conscious, cooperative. Pulse is 78, BP is 3190. Saturation 98% in room air, respiratory rate 14. No pallor, sinuses, traveling chest, edema, or lip neuropathy. No knuckle hyperpigmentation, no ulcers. Gross ENT examination, ma'am. In ear, there is no scar marks, ear discharge, or tenderness or deformity over either ears. Nose, there is no swelling, tenderness, or nasal discharge over the nose. And examination of the throat, there is no nasopharyngeal mass visible, sinuses, or swelling or scar mark over the throat. Higher mental function is, ma'am, normal, alert, conscious, cooperative, and well oriented to time present person. Speech is, ma'am, hoarse. He is able to speak in hoarse voice. Cranial examination, ma'am. The first olfactory nerve is normal smell over both nostril tested. Optic nerve is normal, ma'am. Pupil is normal light and consciousness reflex visual acuity is 6/6 with the refractive correction. Color vision is normal. Visual field is normal by confrontation test. Fundus is normal disc and macula over both eyes. Oculomotor nerves, 3rd, 4th, and 6th. So there is no abnormal protection of eyeballs. No drooping of eyelids, no ocular misalignment, extraocular movements are normal. No restriction in horizontal or vertical gaze. Saccades and pursuits are normal. There is no nystagmus.
Okay.
Cranial nerve examination, ma'am, there is normal, ma'am. Sensory and motor parts are normal. Jaw reflex is normal. Then
Okay.
seventh facial, ma'am, the motor functions. There is flattened nasolabial fold with smoothing of the forehead wrinkles over the right half of face. Widened palpebral fissure of the right eye. Incomplete closure of the right upper eyelids on attempted eye closure. And there is facial asymmetry with the deviation of angle of mouth towards the left. There's absent corrugation of eyebrow over the right half of face, leakage of air from the right side of angle of mouth on attempted puffing out of cheeks, reduced movement of the platysma over the right side on the attempted inversion of the lower one. Sensory function, ma'am, the taste is normal, ma'am. All the sweet, sour, and salty taste on aspect of both of them normal. Corneal reflex is impaired over the right side because of impaired eye closure over the right eye.
Okay.
This is the ma'am. When the patient is trying to close his right eye, we can clearly see Bell's phenomenon. In this patient, absent forehead wrinkles over the right side, division of angular mouth towards the left, Bell's phenomenon, no movement of the right upper eyelid. Bell's phenomenon clear, and patient is on NG2.
You can open the left eye and see how much rolling has happened in the left eye.
Yes, ma'am.
Then you will see the asymmetry. Grossly, this much rolling doesn't happen normally at
Yes,
all.
ma'am. And in this picture also, ma'am, we can see that as compared to the right eye, the left eye, I think this corneal is bit depressed as compared to right eye, maybe.
Right palpebral fissure is definitely wider.
Wider, ma'am.
And this uprolling of the eyeballs, completely the sclera is exposed on the right side.
Yes, ma'am.
On the left side, I'm sure it is not just the visibility of the uprolling of the eyeball. It is a breaking down of the syncytial. You will see, I am sure that the left eye, this roll is not much, but only thing to open and see.
I will see. And the patient is on hearing aids over the both the ears, ma'am. You can see it. Then eighth nerve examination, ma'am, cochlear functions. Reni's chest, ma'am, is normal. Air conduction is greater than bone conduction over both ears. Weber test lateralizes to the left eye because right eye is more severely involved. This test were done with hearing aids removed. Absolute bone conduction test is impaired over both sides. Vestibular
Right
functions,
there is total deafness, right side?
Yes, ma'am, right side is nearly total deafness. Vestibular functions, ma'am, are normal in these patients.
Okay. Then you will not say that it is a lateralization to the left side.
Yes, ma'am.
You can say the right side is tone deaf. So nothing can be heard on that side.
Right.
So it is, that way you have to explain. Okay.
Ninth, ma'am, I've tested, ma'am. There is impaired gag reflex over the right half of posterior pharyngeal wall. And on touching the posterior pharyngeal wall, there is impaired touch sensation over the right side of posterior
So
pharyngeal wall.
opposite side palate, is it moving? When you touch the right side, opposite side it is moving because the stylopharyngeus is a very weak muscle.
Yes,
only the ninth nerve is alone involved. You will find some asymmetry of the soft palate due to stylopharyngeal. Otherwise, all other muscles are supplied by the 10th nerve. It is much stronger. It will not be, motor component will be difficult. So sensory, of course, as you said, like the touch feeling. And you can look at the opposite side moving. Consensual will be absent when you check on the right side if the ninth is involved.
Then examination 10 nerve, there is impaired gag reflex over the right half of posterior pharyngeal wall. On attempted phonation, the uvula deviates toward the left side, and there is hoarseness of the voice present. I will show you the videos now. In this picture, not very clear. There is a video I will show.
Great.
So this is very much obvious, ma'am, that the uvula.
Yes, yes.
Okay. Uh, on 11th nerve examination, there is normal tone and bulk over bilateral sternomastoid muscle. There is normal power over the bilateral sternomastoid muscle. There is reduced bulk for the right trapezius muscle, maybe due to ma'am 33 years back he had a fracture of humerus and is not moving this right shoulder. That may be because of disuse atrophy. This slight sagging of the right shoulder, and on shrugging the shoulder, right side is slightly weak, left side is normal. 12th nerve hypoglossal is normal, ma'am. There is no deviation of tongue over either side in resting position or on tongue production. Normal tongue power, no visible fasciculations, no visible atrophy of the tongue. Motor system examination, ma'am, tone is normal. Bulk, as I said, in the upper limb, there's wasting of the right supraspinatus and trapezius, increased hollowing of the supraclavicular fossa. That is more likely because of the diffuse atrophy, ma'am. We can see right side and the left side is that supraclavicular fossa is more prominent and supraspinatus is, ma'am, wasted.
Yes.
Power, ma'am, shoulder, right side, there is a limitation of range of movement, and right shoulder flexion extension is a bit weak, 4+. Abduction is able to do only for first 15 degrees. Adduction is, ma'am, full, 5. Left-sided power is full. Elbow, wrist power is full. Hand grip and small muscles power is normal. Lower limb power is normal, ma'am. Muscle stretch reflexes, right-sided corneal reflex is impaired because of the weakness of the right orbicularis oculis muscle. Conjunctival and abdominal reflex is present. Plantar are flexed toward both the sides. GTRs are 2+ all over except ankle, which is sluggish. Sensory system, ma'am, over the right and the left is intact all over. Rhombox is non-negative.
Yes, ma'am.
Cerebellum, ma'am, is normal in the upper limb and the lower limb.
So now after examination, is there anything additional other than the cranial nerves?
No, ma'am. No, ma'am. No, ma'am.
So now tell me the structures involved.
So it is 8 nerve, ma'am. Especially the cochlear nerve. The and 8 nerve is involved. 7 nerve is involved. 10th is involved, and possibly 9th is also involved. And
yes,
all is
9th is involved. You told that the sensation is not. No?
Yes, ma'am. And all of the nerves is involved, ma'am. LMN.
Yes.
LMN is type of weakness is there.
After examination, only thing, even though there is some pain, you said, we are not getting definite evidence for a ENT involvement.
Yes, ma'am. No ENT involvement.
Apparently, ENT examination is normal. So if you draw the picture of the skull base, which I have shown, you can only put the lesion as carpeting the skull base from the medial petrous region, bilateral probably medial petrous, and on the right side, it is spilling over to the middle, between the middle cranial fossa and the posterior cranial fossa. So I always tell supranuclear, nuclear, intraxial, fascicular, cisternal, skull base, foraminal, soft tissue plane. So because you are not finding any other ENT feature, I feel it is in the skull base.
Skull base.
So after examination, it favors a skull base in the middle cranial fossa, spilling over to the posterior cranial fossa, right more than left. So next, so you have one more additional, whether it is a pachymeningitis.
Yes, ma'am.
So that becomes an additional differential diagnosis because ENT examination is completely clueless. So we will add one more differential diagnosis, whether it is a
pachymeningitis.
Okay.
So
What
after
tell.
So after the history examination, we made a proof that is a probable some skull base pathology could be there. So we investigated the patients. The routines, ma'am, CBC were normal. CRP was raised 67. ESR was 79. There was hypernatremia, which we corrected. LFT, RFT were normal. HbA1c was 6.3.
Mm.
Then we did CSF, ma'am. CSF was normal, ma'am. Has 2 cells, so for 45 protein, glucose 61.9. Gene expert, cryptococcal was negative. Blood and CSF culture were no growth.
Mm.
Serum vasculitis profile were negative, ma'am.
Mm.
Then we did MRI. In MRI,
Yes.
we find that picture of right maxillary and ethmoid sinusitis with abnormal star hyperintensity in the
But it is very surprising with this much involvement, END was normal. END
yes,
exam.
ma'am. Yes, ma'am.
They did a nasal endoscopy, yeah, END people.
Yes, ma'am. They did.
That
But
was
I will show
normal.
you. No, ma'am. Not normal.
So,
So
it's a gross bedside END examination was normal, no?
yes, ma'am. Gross was normal, ma'am.
Mm.
And in the MRI, we can also see over the pachymeningitis, ma'am, right side. This meninges are also involved
Mm.
near the temporal region.
Yes.
Then we also did a PET CT for this patient.
Mm.
PET CT, ma'am, it is showing this FTG already along the right jugular foramen, right caput space, right pterygoid region, foramen oval, meninges of the right temporal lobe,
Mm.
and this mucosal thickening involving the right maxillary and right ethmoid sinus,
Mm.
likely infective or inflammatory etiology.
Mm.
Then we took an ENT opinion, diagnostic nasal endoscopy was done. There was inflammatory tissue was noted within the maxillary and the ethmoid cavity. And these inflammatory tissues were taken for gram smear and bacterial culture sensitivity, fungal smear and culture, TB panel, and histopathological examination.
Mm.
Histopathology, ma'am, HP showed inflammation with some histocytic reaction with foci of necrosis were there. Fungal cultures were negative, gene expert were negative. But that culture of that tissue showed growth of cons and pseudomonas.
Mm.
And we started him on we made a diagnosis of skull base osteomyelitis. And antibiotics were given as per the sensitivity reports. 21 days antibiotics, ma'am, meropenem and levofloxacin. It's going.
Mm. How is he now?
Ma'am, facial palsy is still there, ma'am, persisting. But overall, his ESR and CRPs have come down. Generalized that feeling of betterness is feeling. But facial palsy, ma'am, it's still there. Facial palsy and hearing impairment.
Palate still there.
Palate, ma'am, is still there. He's still on NG feeding. We are doing the solo assessment, but still there has been slight improvement. But ma'am, they told to
So what we
keep.
have, so I don't know why you went for PET scan before the
Ma'am,
nasal
after
endoscopy.
after MRI, we went for PET scan, and
Nasal endoscopy would have been sufficient.
yes, ma'am, because
He's an
in
army
this,
man, of course, affordability will be there. I think the
yes, ma'am.
otherwise, because PET scan is not that wonderful for a locally invasive lesion. Supposing you have confirmed it is malignancy and you are looking for meds anywhere, then it will be, because I am a middle class doctor and I never advise complicated tests for my patients. That tendency should stop, ma, because but I find now your younger generation people endlessly chase everywhere and you find so many incidental lesions and leave off the elephant
Yes,
and,
yes, ma'am.
and treat the incidental lesions which have nothing to do with the patient. So
Yes, ma'am.
do this kind of things, so it should not be a man-machine relationship. It
Yes,
should be man and patient. It's all a very short duration disease.
yes, ma'am.
So it may be a refractory infection. You may have to reculture and recheck and look for resistant organisms, super infections. And one thing we always tell, they can still have an underlying malignancy, which is, of course, that part of it might be helpful with the PET scan. Even that, I am not very much happy to know local pathology with the PET scan. But we say that the super infections will be there. because the person's response is not so good. So be watchful, because you may have to, after clearing the infection, you may have to repeat the biopsies.
Yes, ma'am. That's our plan.
Yes, that it might show some neoplastic pathology. So first thing, I would never have done PET scan for him. That is, as I said, I belong to older generation and middle class doctor. He's not an upper class doctor. So before, my teachers have told, before you order any test, you ask two questions: which will help, will it help the patient or will it help science? So in this situation, I don't think there is an indication except making him pay his money, and it is taxpayers' money for him now. No? He's
He's been ECHS, ma'am, covering. So government is paying for his investigation.
Government means us, no? Sovereign Democratic Republic.
Yes, ma'am.
I am also working in an ECHS hospital. So what I find, nobody has gallbladder, and nobody has tonsil, nobody has uterus, and everybody has knees replaced. These are all wild goose chase. Yes, these people, it is free. They go to every department and donate their organs.
Yes.
I never allow that, and I chase them out. You see, organs can be taken out for free, but you'll not get it back. So I chase my patients. Don't chase hospital because it is free for you. Losing organ is free. That's okay. It's really a tragedy I see in my hospital. Every department takes out one thing. It should not happen. So that's why I feel most army people are very sick. They don't have coronaries. They'll have a muscular pain, and then they undergo an angiogram. There some subtle block will be there. So after the stent, the disease evolves. These kind of things everywhere. Actually, we do harm to our patients. So that is my personal opinion. Of course, you can choose whatever way you like. So my question, I just remember this question: will it help my patient or will it help science? Is it for a research purpose or is it for a determining the nature of the disease, for which the best thing is the histopathology?
Yes, ma'am.
So always ask like that, because the science deviating into a machine-patient relationship is very dangerous. I am really seeing it now, working in an ECHS hospital. I tell them, because it is free, don't donate your organs. I tell them when they come to my department. They go around shopping every department. Everyone will take one organ. Thyroidectomy, terrible, small nodule to the thyroid. And after the thyroidectomy, they develop recurrent laryngeal nerve palsy. It would have kept quiet there. Small nodule. Surgeon will tell remove because it is free. Removed and procedure for the hospital. And recurrent laryngeal nerve palsy is okay. They develop hypoparathyroidism, hypothyroidism, dementia, basal ganglia calcification. And I saw a very young lady recently for a benign nodule like this. She developed an anesthetic accident and now lying like a vegetable. Because you are young boys and girls now, you might not have seen all this. So the dictum in medicine is don't do more harm.
Yes,
You may
ma'am.
not help them. I am seeing all this. I cannot open my mouth because our own colleagues are doing all this. And I cannot tell, as a retired person working in a ECHS hospital, if I tell something, the whole army of doctors will become my enemies. I don't open, but now I can tell you because it is still you are in the shaping. It's not learning, it is a shaping of a doctor.
Yes, ma'am.
Yes, it's a divine profession. As all of us know, there is no better profession than a doctor's job.
Yes, ma'am.
And if you are a teacher also, it is double divine. Teaching and doctoring are the most divine jobs in the world. And you should not make it into a business.
Yes.
You see, many people justify. At this age, I can tell you, because you are still not crossed the Rubicon. No? After that, you will have your own decisions. People go to 10 hospitals, 5 minutes for a patient, and all investigations available, and treat soft shadows. Then you are damaging the Janma given to you for the two Punya professions, teaching and doctoring. It is terrible. When I
Yes.
see, I feel like hitting my head and dying. So if you want to make money, you sell alcohol or do some do an exceptional activity, which people are doing. It's so easy. It's not at all difficult. And why
Yes,
get
ma'am.
the most precious degree and misuse it?
Yes, ma'am.
Never do that. No. So
In your classes, ma'am, we get knowledge and values both. That is the.
so nice. So keep him under follow-up. Repeat the biopsy.
Sure, ma'am.
And okay, nice one.
Thank you, ma'am.
Thank
Happy
you,
wishing,
ma'am.
ma'am. Thank you.
Thank you.
Thank you.